Hi, everyone. We're here with the CLL Society, and we're going to run some interviews regarding some abstracts presented at ASH in 2021. I'm Alan Skarbnik. I'm the Director of CLL and Lymphoma Program in Avant Health Cancer Institute, and I'm here joined today by Dr. Constantine Tam, who will introduce himself.
Hi, I'm Con Tam from the Peter McCallum Cancer Center and University of Melbourne in Melbourne, Australia, and I am a CLL doctor.
Glad to have you here, Con. Thank you for coming to the interview, even with a significant time zone difference between us. There are a couple of abstracts I'd like to discuss. You were co-author on them. So let's start with the first one. Abstract number 67, Zanubrutinib in combination with Venetoclax for patients with treatment-naive CLL or SLL with deletion 17p. These are the early results from the Arm D of the SEQUOIA trial, BGB 3111304. So if we could go over the study and what the findings were. This is a very important study, particularly looking into fixed duration treatment for patients with high-risk CLL and SLL.
Sure. Thanks, Alan. So I think for me to describe this study properly, it might be helpful for me to describe the overall structure of the study. So the SEQUOIA study was initially set up as a randomized study of frontline CLL treatment. And these are patients who have never received treatment in the past, who needs therapy, and they're randomized to either Zanubrutinib or bendamustine rituximab. Now, we actually reported this study at ASH as well, and not surprisingly, Zanubrutinib is better than bendamustine rituximab as first-line treatment for CLL. But as part of this study design, we were trying to debate what to do with patients who were identified to have 17p deletion, because as your audience may know, if you have a 17p deletion, you're not suitable for chemotherapy, and it would be unethical to randomize these patients to bendamustine rituximab. So those study patients were initially put into what we call the Arm C, which is a non-randomized arm, where patients got single-agent Zanubrutinib, and we've previously reported that these patients did very well on single-agent Zanubrutinib. And then in the course of the study, we then thought to ourselves, well, everyone else is doing, ibrutinib Venetoclax type combination. This would be a really interesting population to study the Zanubrutinib plus Venetoclax combination once we ran out of spaces on the Arm C. So we opened Arm D, and these are once again patients who entered the SEQUOIA study who have found to have 17p deletion, and they were enrolled to essentially Zanubrutinib for 3 months, followed by a Venetoclax ramp up, and then the combination of the two drugs together. We really weren't expecting anything unusual because we knew that ibrutinib plus Venetoclax works well. We know that Zanubrutinib is at least as safe as ibrutinib. And the results that we reported are really only very early, and really just to show that this is a combination of Zanu and Ven that is feasible. It doesn't have any unusual toxicities. It's well tolerated, and so far the responses are as expected, which means that most patients went into a very deep remission. We didn't have any MRD results because things are so early in the course of this arm. It was really just to say, hey, this is possible, and watch the space as we complete the enrollment.
That's amazing. That's a great effort, I think that obviously this is a underserved population, especially in the newer trials, but it's the reasonable rationale to combine novel agents that don't really have overlap toxicities to treat this patient population. So we're eagerly waiting for further results from the study, but the preliminary results, as you pointed out, are very encouraging. Thank you so much for that.